Okay. So when we talk about COX-2 inhibitors, why would it be better? Turn to your buddy and explain, why would it be better to inhibit COX-2 than just to inhibit COX-1 and COX-2? Right. So we think about COX-1, protect your stomach. COX-2, punch him in the face, right? So if we're inhibiting COX-2, we are stopping the pain and inflammation, but we are not taking away that protection for the stomach, right? Also, we're not causing issues with anticoagulation. So COX-2, does that seem like it's better? Okay. But next to that, I want you to put a little asterisk, because if you take too much of a COX-2 inhibitor, there is bleed over, so that it actually starts inhibiting COX-1 as well. The other thing is that for the elderly, the COX-2 inhibitors don't stay with just the COX-2 as well. In the elderly, we see a lot, sometimes that the COX-1 actually gets inhibited more than in younger people. Okay, so that's just part of their metabolism and the way it shows itself, so the pharmacodynamics. It does decrease the high risk of GI effects. Even in older people, it's just not as good as in younger people. Okay, there's some things. Have you seen Relafin or have you seen Mobic? No? Okay, those are kind of common. Those are other drugs that you might see. All right. We want to assess our renal function. Right, not so much that it's not so hard on the liver as much as it is on the kidneys. We're still assessing the GI status just to make sure there's not too much bleed over. And look at our side effects. Not too bad, right? Headache, dizziness, nausea, diarrhea, sinusitis. And that has to do with, the sinusitis has to do also with the effect it has on histamines. But that's a little more complicated than where we need to be for this class. Okay? Any questions about this? Yeah?
Are there over-the-counter COX-2 inhibitors?
So there's a generic for Celebrex. The Celecoxib is our prototype for this one, and there is a generic over-the-counter. They used to all be prescription, but now they do have it over-the-counter. All right, so that's what we have for as far as inflammation, as far as things that treat inflammation and pain, just kind of straightforward. Now we're going to talk about autoimmune disorders. What's an autoimmune disorder? Right, the body is attacking itself. So it has to do with the immune system being overreactive, and so the body is attacking itself. And we think about, there's a lot of them, but the ones that we see a lot of are rheumatoid arthritis, MS, which is multiple sclerosis, and then lupus. Okay, does anybody know somebody with one of these three things? So unfortunately, we're seeing more rates of these climbing, but we have gotten much better at treating them. Okay, what's the problem with trying to treat somebody for pain or for a process going on in their body that their body is causing for themselves? What do you see conceptually? If we know that it's their immune system that's causing this problem, it makes sense to try to suppress their immune system, right? So one of the things we could use is prednisone. Does that make sense? And then, do you remember with the long-term, turn to your buddy and say one long-term effect of being on prednisone. Excellent. Thinning skin, buffalo hump, stretch marks, change in hair, lots of things, right? Change in moon face, right? Change in personality. So we have to try to find a way to control the pain and try to control the issues. We used to use gold drug therapy. So we used to use something, for some reason, the chemical components in actual gold stops the autoimmune process without causing some other side effects. So I had a patient at my first NP job that would come to our office every week, and she would get, or every 2 weeks she would come, and she would get this injection. It had like little flecks of real gold in, just like in like this fluid stuff. And we would inject it into her butt. Her buttocks were so scarred from so many years of it, but it was the only thing that controlled her pain. So, but we don't use that so much anymore. So we use some immunosuppressive agents. We're going to be talking about these immunomodulators. And then drugs that control malaria actually also help sometimes, but they're not as strong as some of the newer stuff. So we're going to talk about, so this class is called tumor necrosis factor. What does that sound like it deals with? It sounds like cancer, right? It sounds like it's stopping cancer. The things in our body that stop cancer, did you know that you have antibodies in your body that will stop cancer? We found that we don't have to suppress the whole immune system, but for some reason, the things that try to stop cancer in our body If we can stop those, then it helps a lot of the symptoms for people who have the autoimmune issues, okay? And so these are the medications. Have you heard any of those? Enbrel, Remicade, Humira? Yeah, they're on, Humira has a lot of commercials on TV right now. Yeah, they certainly do. So these are going, by neutralizing this tumor necrosis factor, it disrupts the inflammatory process and it delays disease progression. It's super important, write this down. These diseases cannot be stopped. They are progressive. No matter what we do, those diseases will progress. But this just delays the progression. Okay, so it delays the joint damage or whatever it's doing to your organs. So these, let's see. All of these autoimmune disorders, it's not just that they cause joint pain, they're actually causing, they're actually causing damage to people's organs and to their joints. So see how this person's fingers are starting to bend? In rheumatoid arthritis specifically, there's little crystals that start to build up in the joints, and that causes deformity, it causes changes in the joint. See how this looks really red and hot? That's really common of autoimmune issues, okay? See how those bones are a little bit different? We're learning that see how the joints are kind of swollen there? And then people can get little nodes called Haberden's nodes on different things. And this is just the hands. This can happen to all of the, this can happen to any of the extremities, okay? And that's just the effect that it has on the joints. It also has issues with some of the soft organs, with anywhere there's connective tissue, there can be issues with these autoimmune disorders, okay? So these drugs don't just help with the pain, they also help slow down the progression of the disease. All right. So what Humira is the one that is going to be our, losing my chalk. Humira is going to be our prototype for this one, and all you need to know is that is this stuff. That's delaying disease progression, it's not stopping it, it's disrupting inflammatory process, and it's neutralizing the tumor necrosis factor. We don't have to get into it too much, because it's a little bit above where we need to be for our class, but if it's messing up the thing that helps our body's natural cancer fighters, what do you think is a side effect of these drugs? Cancer. So unfortunately, and you don't have the regular warning signs of it. Specifically leukemia and some GI cancers. Okay. This is not something you're going to be tested on, but whenever you see MAB at the end of a drug, it's typically an anti-cancer drug. Okay. The MAB stands for monoclonal anti-nuclear bodies, and it has to do with how that drug works. But if you see MAB at the end of a drug, just think it's probably something to do with cancer. Okay. All right, so now we're going to talk about gout. Does anybody know somebody who's had gout? Yeah, how does it feel? Not good, right? Noel, do you want to talk about it? What does it look like, or?
My uncle, he gets it sometimes, and he stays in bed because he can't even walk out as well.
It's so incredibly painful. So we think about it usually happening in the big toe, okay? Your uric acid builds up in your, where does uric acid has to do with like the kidneys and how we're getting rid of just different kinds of, there's a whole bunch of things that go into making uric acid, but if the uric acid builds up, it makes crystals, and those crystals float around our body. And so they get lodged sometimes in the big joints of our toe. Sometimes they get lodged in our knee. It can really get lodged anywhere, but the big toe, for some reason, is where it's really common for these to get captured. See how red and angry this is? And people talk about like just even having a sheet on their toe or on their foot, wherever it's affecting, is super painful. So, so this is hard for people. Sometimes it's just that people have been eating too many foods that have purines in them. Purine is a special kind of protein that for some people it's hard to get rid of. Other times people have an increase in uric acid for some reason that's causing it. But you need to know these purine-containing foods, okay? So you know that drinking alcohol, eating bacon, can you imagine? Seafood, shellfish, venison. Does anybody in here like venison? Yeah. You too, Alyssa? Do you have anything up? And veal and sardines, and then aged meats or organ meats. Okay. So our vegetarian friends, our vegan friends, they're A-okay. You need to know 3 different kinds of anti-gout drugs, and this is all you need to know about them. Okay. When you look at this slide, it's very specific about what you need to know. Uric acid inhibitor and uricosurics, they are both aimed at decreasing uric acid levels. Okay, so whether the uric acid is rising because you're eating too much of the high purine foods or because something's going on in your body that you're creating a lot of uric acid, you could take either allopurinol or probenecid. Okay. So know that this one decreases the uric acid levels, and then this one just blocks the reabsorption of it. Both of these, the 2 bottom ones, are both used for like prevention, maintenance kind of stuff. Okay? These are both used for maintenance or prevention. Colchicine is the one that we're going to give in case of an acute attack. Okay? And colchicine just stops more leukocytes from flooding to that area. What are leukocytes? White blood cells. Why would your body send white blood cells to an area? Right, that's causing inflammation, it's trying to heal it, but that inflammation actually causes more pain. So the colchicine, of these 3, colchicine is the only one that we're going to give to somebody during an acute attack. The other ones, we can give these during an acute attack, but they can stay on these long term to keep the uric acid levels down. Okay? Right. Any questions about that? Okay. All right, so that was all the drugs that we talked about so far. We're coming at pain from kind of like a back doorway. We were addressing inflammation. Go ahead.
Would the acute attack just be like a flare?
Yeah. Yeah. So it's like, I know I have gout, but right now I don't have any symptoms. But when all of a sudden my toe starts to get real red and painful, that would be an acute attack, and now I'm going to hop on my colchicine. Good job. So all the drugs we've been talking about so far have been addressing pain sort of indirectly. It's taking care of inflammation, or it's trying to suppress different things going on in my immune system, right? Now we're going to talk about pain medications that are purely for pain, okay? So, oh, I went the wrong way. Did I go the wrong way? No, okay. So acetaminophen, what's the brand name for acetaminophen? Excellent. So acetaminophen is not an NSAID. And the approved abbreviation for it is APAP. Can you say acetaminophen? Have you ever seen APAP on the end of a drug name in the hospital? Do you have an idea what went on the front of it? Yeah, hydrocodone, oxycodone. So we are doing a synergistic effect. When you see like hydrocodone plus APAP, it's a synergistic effect between an opioid and acetaminophen, which is not an opioid, but it's really directed towards pain. Okay. All right, here's the thing with acetaminophen. Unfortunately, acetaminophen is incredibly toxic to our bodies. It also, unfortunately, people don't realize that it's so toxic, and it tends to be the drug of choice for people who are suicidal gesturing. What does it mean to be suicidal gesturing rather than attempting suicide? What?
Thoughts of suicide.
Thoughts of suicide. Good. Melissa?
I was kind of going to say that.
Okay, so basically, suicidal gesturing actually is still attempting suicide. It's just that I'm a little bit nervous about it, okay? Nobody grows up and says, I hope I grow up and commit suicide. But what happens is, go ahead, Melissa.
Are you kind of talking about like somebody that like they'll try to like overdose, but then they call out like ambulance?
Mm-hmm. So that could, there's a lot, suicidal gesturing can look like lots of different things. But what happens is people start to get depressed, they get to a low place, and when people are happy and things are going well, nobody ever thinks that suicide is the way to go. And a lot of times when people are thinking about committing suicide, they don't start off saying, that's it, I'm going to end it all. They start off just feeling like they're in a lot of pain, and I just want this to end. I'm just tired of this. I'm just feeling really weighed down. I just wish I could get this to end. And then suddenly those thoughts start seeming not so bad. They don't seem so scary. And so typically there is kind of a long process that's going through. And we see sometimes that people say, you know what, I'm just going to take a bunch of pills and go to sleep. It seems in the 60s and in the 70s, there were a lot of, unfortunately, actresses, Marilyn Monroe, some other people who were just like, I'm going to take a bunch of pills and go to sleep. And for some reason, people sort of romanticize that. And so we saw that after we see somebody famous do something like that, we see more people do that. But when I worked in the emergency room and working as a nurse practitioner, I see a lot of people just say, well, I just took a handful of Tylenol because I just was tired and I just wanted to go to sleep. Is Tylenol going to make you sleepy? Really, no, right? But that's a suicidal gesture, right? So how do you know if somebody took a bunch of Tylenol? How would you know if it was an attempted suicide or attempted like a suicidal gesture, or that, oh, I just forgot that I took my Tylenol this morning and I took more?
I think like if somebody is like trying to commit suicide by taking a bunch of pills, they're usually like found by somebody else. Like it's not usually them like.
Okay. So sometimes, so Melissa says that maybe they won't try to get help. Maybe sometimes somebody will find them. That's true. Sometimes people get scared. Sometimes people take a whole bunch of pills and they go, oh my gosh, what did I do? They have that moment of like, I call it a moment of clarity, but maybe they don't look at it that way. I guess that's a matter of opinion. But they have that moment of like, oh my gosh, what did I do? But you're right. There's some recognition by somebody else or by that person of, this is not what we wanted to do, right? This isn't what we wanted to happen. Typically, people who overdose on Tylenol without the thought of suicide or hurting themselves, they're really surprised that they took so much. You know, there's just different incidents. How are you going to find out? What are you going to say to somebody? Let's say that I come in and it turns out that I took all this Tylenol. How are you going to ask me questions? What questions do you want to ask me to find out what my intentions were? Jenny?
Are you feeling down, depressed, or suicidal?
Yeah, are you feeling down, depressed, or suicidal? How many people think that that would work? Am I going to tell Jenny that I'm suicidal? I'm going to be honest with you, a lot of times people who are truly suicidal, so there's two things. If I'm not suicidal and I was just thinking about it, I might not tell Jenny, right? But there comes a point where people are feeling really, really desperate, and they're just feeling really desperate. They're close to committing suicide. It's really on their mind. We have survival instincts, and people really will tell you. If you come out and you ask somebody, were you thinking about hurting yourself? Were you having any thoughts of this? You're going to be surprised how many people tell you, yeah, I was feeling kind of low. I think I was trying to hurt myself. Yeah, I think I didn't really want to wake up. And I don't know about you guys, but the first couple times when I asked somebody and they said yes, it surprised the crap out of me. And I thought, oh, now I don't know what to say. I got this far. What do I say? I will also say something else about suicide, though. People get to a point where they're 100% sure that this is what they want. And you have to know, going into this profession, if somebody wants to kill themselves and they're just really like, they've been through all the stages of grieving and they're just like, this is the last thing I can do, whether they lie to you or whether they're telling you the truth, if somebody ends up taking their life, there's really only so much that we can do. And you have to be careful. I've taken care of some people who were very suicidal, and there was one person who was 19 when I was a nurse practitioner that we kept doing like suicide attempts. We just kept trying to like pull him back and do all these different things, and he told the time before he actually succeeded, he said, you can keep stopping. He said to his parents, like we were in our office, and he looked at his parents, he was like, you can keep telling me that you can keep stopping me, but this is going to happen. And then the next time he was successful. And sometimes there's just only so much you can do, so you have to be careful about how much of that you carry with yourself as a nurse, okay? But when you ask somebody, did you do this because you were thinking about hurting yourself? Your next question is always going to be, do you have a plan? Okay, write that down. So your first question is going to be, was this intentional? Were you thinking about hurting yourself? And you need to be direct. You can't beat around the bush, right? You can't say, you weren't thinking about hurting yourself, were you? If Evan's my nurse and Evan says, well, you weren't really thinking about hurting yourself, were you? What is he setting me up to say? No. Yeah. Oh no, I wasn't, right? Because he's telling me that he doesn't really want to know. But Evan, being a great nurse, Evan's going to say, he's going to look me square in the eye. He's going to get at least at my eye level, maybe a little bit lower, and he's going to be completely sincere when he says, have you had thoughts of hurting yourself? How can I lie to that, right? It's going to be hard. So sometimes, when you go to the doctor's office and they have their back to you and they're doing the computer thing and they're asking you their questions, do you wear a seatbelt? Are there guns in the house? Blah, 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 blah. Do you eat your, 4 food groups a day? Do you have any thoughts of hurting yourself? Are they looking for that when they're asking questions in that way? They're not. So we need to make sure that we're very careful about that, okay? All right. So the reason why Tylenol is so dangerous, though, is that it is toxic to our liver, okay? It is incredibly toxic. It has a very narrow therapeutic index. So much so that the max you can have a day is 4 grams a day. Regular Tylenol is 325 milligrams. Extra strength Tylenol is 500 milligrams. People take the extra strength Tylenol 2 pills at a time. How many times can I take extra strength Tylenol for my arthritis and still be okay? How many tabs can I take a day? 8. 8. So that means 2 pills every 6 hours. What if I take 2 pills every 4 hours? What did I just do to my liver? I just killed my liver a little bit. Okay? Tylenol, you know how like when you drink alcohol, it kills brain cells every single time you drink alcohol? Tylenol does that to your liver. Every single time you have some Tylenol, it's killing your liver a little bit. Okay? Go ahead.
So is like an NP, like, if you were to tell someone to take ibuprofen versus acetaminophen for pain, which one would you recommend?
So I was going to get to that, but again, Evan did a great job beating me to it, and that's a good thing, Evan. That's not bad. I want you to make this little chart in your notes. Okay? We're going to talk about ibuprofen, and we're going to talk about acetaminophen. Okay? Ibuprofen, does it take care of swelling? Does ibuprofen help with swelling? Yes. Does ibuprofen help with fever? Yes. Does ibuprofen help with pain? Yes. Does ibuprofen, is it hard on the liver or the kidney? Kidney. A little bit more on the kidney, but let's say, but it's not that severe. It's a little bit hard, but we're going to say a little hard on the kidney. Okay? Acetaminophen. We haven't really gotten that far. It relieves pain, discomfort, and fever. No swelling. It doesn't help with swelling. So there's no swelling. I'm going to put swelling, and then we're going to cross that out. Does it help with fever? Yes. Does it help with pain? Yes. Is this hard on your liver or your kidney? Your liver, and we're going to say easily toxic. It's got a narrow therapeutic index. Okay? Here's the thing. Ibuprofen affects prostaglandins. Acetaminophen doesn't. So who could I give Tylenol to that I can't give ibuprofen to? Pregnant women, right? So this is going to affect prostaglandins. This one doesn't affect the prostaglandins as much. Okay, going back to aspirin, just a second, okay, Macy? Going back to aspirin, remember we talked about aspirin we're never going to give to children who are recovering from a viral illness, right? Who have a fever because of a viral illness. You can give either one of these to kids, and they won't get Reye's syndrome. Okay, it's just aspirin that causes the Reye's syndrome. So there's going to be a question on NCLEX, there's going to be a question on the exam. Here are your choices to give to a child. Aspirin, acetaminophen, Pepto-Bismol, something else. What are you going to give them? Acetaminophen or ibuprofen. We're not going to give them aspirin, okay? Macy.
Between the two of these, one should you take with one without?
This one, that's great. Let's add GI discomfort. This one has GI discomfort.
I remember getting Tylenol when I had like a really bad sore throat and they not to eat with this.
They told you to eat with it?
No, they said
Yeah, and it has to do with this is affecting the COX-1, and this one doesn't. So this works on a completely different pathway. Okay. So that's why, like, if we stagger drugs, if we have a fever, a really bad pain, I can give ibuprofen, and then 2 hours later give Tylenol, and then 2 hours later give ibuprofen. Does that make sense? As long as I'm keeping the ibuprofen doses away. Go ahead, Amanda. This is okay. No, thank you. Thank you. Does that help? Okay. Yes.
Mgmt, when you take acetaminophen, it like adds a functional group to the toxic
Yes.
compound.
I just think you guys are the best because that's where we're going, right? So acetaminophen, if we overdose on acetaminophen, our antidote is Mgmt. God bless you. Or acetylcysteine. And there is a slide in this, okay? And Mgmt, you'll remember from when we did respiratory in week 3, has to do with just loosening up the congestion, but it binds and it prevents us from taking in the acetaminophen. Go ahead, Emily.
How often is aspirin really used as a pain medication?
Aspirin? Not as much, because there's a lot of side effects to it. So
Like in the hospital, you would only see aspirin as an anti-inflammatory.
yeah, we don't use aspirin a whole lot because it's so hard on the stomach, and the anticoagulant properties are really, or antiplatelet properties are really strong. Go ahead, Amanda. So caffeine, we're going to talk about migraines in a couple of weeks, but when you see caffeine added to something, they're probably intending it as a migraine medicine. Caffeine helps stabilize the blood vessels in your brain, and it helps stabilize them so that your head stops throbbing. So, and we'll talk about that a little bit more. Yeah.
Do they do regimens? I know we haven't talked about like opioids yet, but do they do regimens of ibuprofen and Tylenol?
So usually we see it like if somebody has like a little kid has a fever that won't come down, or if somebody's having really severe pain and we don't want to use an opioid, they go back and forth between the ibuprofen and the acetaminophen. Okay, and the reason they do that, so I just want to make sure I'm clear about this. If I give ibuprofen at noon and I can't take it again until 4 p.m., sometimes the ibuprofen won't hold me over. So if I can give acetaminophen at 2 p.m., I'm still keeping the ibuprofen the right number of hours apart. And then I can give this at 2 p.m. and 6 p.m. So I'm getting like double pain relief, right? This isn't going to help with the swelling, but it'll help with the pain. Okay, and that's just something, that's not anything I'm going to test you on.
Do you have to go on like larger doses to kind of mimic if you're instead of taking an opioid, if you're going to do a regimen like that?
No, not always. So there's been some really important research that's been done in the last 10 or 15 years about different kinds of pain actually are relieved better with different kinds of painkillers. And so one of the biggest studies that was this happened like probably 10 or 15 years ago, but they did this huge study and they found people who are suffering from osteoarthritis actually got better pain relief from Tylenol than they did from opiates, from narcotics. So it depends on what's causing the pain, and honestly everything depends on the person's body. So what might work well for one person might not work well for somebody else, so you just have to consider lots of different things. Okay, we are going to talk about opioids today. All right, how you doing with this stuff? You good? Okay, is it okay if I erase this? Because we have to get to more drugs? Okay. All right, so when it comes to Tylenol, though, we've been talking about suicide, we're talking about different stuff, but not everybody who's taking Tylenol is trying to hurt themselves, right? But we have to be careful because sometimes people don't understand the risk of it. The problem with Tylenol toxicity or acetaminophen toxicity is so bad that even though we know that people can handle 4 grams a day, the FDA is in the process of pushing over-the-counter medications to say that the most you can have is 3 grams a day. Just because, why do you think that is?
People will go to 4 grams.
Yeah, right? Because if a little bit works, then how many people have seen somebody, I know nobody in here would ever do this, but has anybody in here ever seen somebody take cough medicine like this? Right? Okay. So limiting how much you can take it make people slow down a little bit. Okay. Okay. So the side effects for Tylenol, not very common, but there is a chance for rash and Stevens-Johnson syndrome. Okay. Toxic effects. So really, we're worried about the liver. Okay. And then thrombocytopenia comes because of the damage to the liver. Okay. So when we talk about acetaminophen, if we find that person or that person comes to us within an hour, do you want to use gastric lavage or charcoal? If it's within an hour, right, then the fragments are probably still going to be in the stomach, so we're going to do gastric lavage. If it's more than that, what are we going to use? Charcoal. Excellent. So hour and a half, we're going to use the, yes. Well, okay, hold on just a second for that. That's because of, I want you to see this Ruminick-Matthews toxicity nomograph. You do not need to, we're not going to talk about this on the exam, but I want you to see it because you may see it in practice, okay? Because the liver issues are so serious with Tylenol, we draw blood 4 hours after ingestion, and depending on where that person is, where they are in the thing, so this is how many hours after ingestion, this is the level in the blood. This tells us if you were under this line, there's no hepatic toxicity. If you were over this line, then there will be probable hepatic toxicity. I had this second or third year that I was a nurse practitioner, we had a patient in our practice that was 17, and she'd hit just a rough patch. Her boyfriend broken up with her, and there were just a lot of like stresses and stuff going on. And her parents weren't home, and she stayed home from school, and she took a whole bottle of Tylenol. Her parents got home at the end of the day. They found her. She was crying. She's like, I'm so sorry, but I took this whole bottle of Tylenol and da-da-da-da-da-da-da. And so they took her to the hospital, and she had taken so much Tylenol, she no longer wanted to kill herself. She realized that there was an issue, but she had taken so much Tylenol, her liver was dying. And she died 2 weeks later. There was nothing that anybody could do about it. You can't go on a transplant list if you were suicidal or thinking about suicide. So there were letters written trying to like explain why she should have a new liver, but unfortunately that family went through a lot. So this is super, super important. Okay. So you won't be tested on what this nomograph is, but just know it for just kind of have in the back of your mind that it has to do with acetaminophen overdoses. Okay. And know that acetaminophen is just really, really hard on the liver. Okay. If somebody has a hangover, if somebody drank a lot of alcohol the night before, let's say like your friend wakes up and they're like, oh, Cynthia, I have this horrible, horrible headache. I just drank way too much. Do we want to give them ibuprofen or do we want to give them acetaminophen? We want to give them ibuprofen for their headache, not acetaminophen. How come? What? Yes. So it's from drinking too much alcohol. Where does alcohol get metabolized in the body? The liver. Okay? So that's a basic thing that everybody should know, that your liver is what's the most affected when somebody drinks a lot of alcohol. So when we're worried about like cirrhosis, we think of like, has this person been drinking too much alcohol, right? Somebody has hepatitis, we know they have to watch how much alcohol they intake. So if somebody has been taking a lot of alcohol and now I take some Tylenol for my headache, what just happened to that liver? It just got hit twice, right? So we use ibuprofen for anything related to alcohol. Okay. Here is so this is talking about. Oh, I see what you're saying about if within 1 hour of ingestion, activated charcoal. You know, I forgot about that. I'm so sorry. The activated charcoal is just because Tylenol is so dangerous if it gets absorbed at all, so that's why they jump to the activated charcoal. But in general, every other drug, if it's an hour, hour and a half after they've taken it, we're going to use the gastric lavage. But this one, we just don't want to risk any absorption. So I apologize that I forgot about that. So if the levels indicate hepatotoxicity, or if we don't know how much they took and it's been 8 hours since the ingestion, we're going to do acetylcysteine. Make sure that you memorize this. Okay? Actually, both of these lines, make sure you memorize those. Okay? And then we're going to be checking the liver enzymes, the bilirubin. Here's the problem with acetaminophen. Because people think that it's harmless, if I give you, so yesterday my mom had surgery, and she got, this is how it was written. Okay, so hydrocodone is 5 milligrams. Acetaminophen is 325 milligrams, right? So 1 tablet every 6 hours. The reason that's actually not a super high dose of hydrocodone, right? If it got to be like 10, 15, 20 milligrams is a really high dose. But it wouldn't be too much to have 10 milligrams every 6 hours. But the problem is the Tylenol dose. Okay, we need to make sure that stays low. So when you are giving somebody more medication, if it's hydrocodone and acetaminophen, we're always watching, trying to make sure that stays in our parameters. Okay, does that make sense? All right. The other thing is that if somebody says, boy, this isn't helping me, and I know sometimes I can overlap, pain medicines, most people think Tylenol is harmless, like ibuprofen. They think of all these drugs as harmless. So they may just take some extra Tylenol. We have to make sure we do a lot of teaching not to take anything that has Tylenol in it. Okay. Okay, so that's our Tylenol stuff. Any questions about that? Any concerns? Okay, so let's talk about opioids. What do you know about opioids? They're what? They are a scheduled drug, right? So they are overseen by the Drug Enforcement Agency, which is abbreviated DEA, right? The FDA keeps a close monitoring on them. There's lots of issues about that. What else do you know about opioids? The opioid epidemic is incredible, right? What do you know about opioid epidemic? It's what? Yeah. Could I have an opioid addiction? Yeah? Could Cherise have an opioid addiction? She doesn't. I'm just picking on her. She happened to be looking down writing, so I'm picking on her. But the thing about when I was growing up, when I was coming up through nursing, when I was coming up through high school, people who were addicts, people who looked clean, neat, organized, had successful lives, nobody ever thought of them as addicts. That's not how it is anymore. It's not just opioids, it's not just heroin, it's meth. Well, meth, your life all of this stuff, your life derails at some point. But there are people who are carrying on lives that look really normal from the outside who have these addictions going on. Okay? We can see that there's a clear timeline, and I'll be honest with you, my generation of nurses is the one that started, well, we didn't start it, but we kind of kept it going. When I came out of nursing school, we were told that if somebody's having pain, as long as they're taking opioids just for real pain and they aren't just taking it like anticipating pain, you could never become addicted. And now we know that it's better if you only take it when you have real pain, that you shouldn't be taking it as like, gosh, I might have a headache a little bit later, so maybe I'll take a hydrocodone now just to be on the safe side, right? But that's what we were doing. That's what we were encouraging people. Well, no, we were telling people that's the only way to become addicted. But now we know even if you're taking it for real pain, different people's brain chemistries will become addicted to that, right? Does anybody have, in your prerequisite classes or in any of your other classes, have you ever studied addiction or how addiction works? Melissa, what do you know about it?
So pretty much it works by things that are highly addictive. It's the dopamine pathway in your brain, so it's like that reward system.
Yeah.
That when you get the rush of dopamine, it's like super salient event they call it in addiction. And your brain, that's like how you make memories. So your brain holds on to the memory of that feeling because of like dopamine.
Right. We see heroin is stronger than some of the pain medications that we're going to talk about. But basically, when you have something that's really some kind of a super strong opioid, it actually changes the chemistry in your brain. I don't think it really happens with codeine, but as it happens as we have made synthetic versions and definitely heroin, it changes the chemistry of your brain. The first time you take it, it changes the pathways in your brain, changes the chemicals in your brain, and your brain always wants it. When you talk to people who have opioid addictions, they always talk about that they're chasing the rush because it'll never feel as good as that first time, but that first time felt so good that people are constantly trying to find that. And the problem is that when we talk to people who have opioid addictions, if they don't keep up taking the opioids, they are so sick, it destroys their life. Like they're incredibly sick, they're fuzzy thinking, they just can't cope with anything. And then once they take the opioid, they have to start taking the opioid just to feel good and just to kind of get through the day. Does anybody know somebody in their family or know somebody who, maybe friends or something, who's had addiction issues? Yeah, it's definitely in my family. Yeah. Do you want to talk about it, Alyssa?
Well, I just got to give CPR to someone who was overdosed before.
I'm really sorry.
Well, it was not a friend of mine, it was actually a roommate. A friend didn't know that she was using.
So you weren't in a professional situation, you just kind of like walked in.
No, I went to pick my friend up, it was like a super snowy night, like around New Year's, and I was going to pick her up and go shopping. And she's like, come inside, like, her name was overdosed. I walk in and go into the room.
Did you kind of freak?
Hmm?
Did you freak out a little bit
Yeah.
when you saw that?
Yeah, I like had to amp myself up to go to CPR. My friend was already on the phone with EMT, and she's like, "You need to do it." She's not into that.
Yeah. Oh, I'm really glad you knew how to do CPR, though. That's a scary thing. We actually had, I don't know if you guys knew Dana, who just graduated in August in the last secondary class. So she was coming home from her capstone clinical, and there was somebody who drove off the road on 31 between Rockport, like that stretch just coming off of 531 there, and where the road is kind of weird. And he drove off, and there happened to be a couple of nurses coming home at the same time, and there was a nurse from Strong, and then I think there was like a fireman or something, somebody that was there. And so you guys are going to do Narcan training next semester in one of your classes, and I don't know if you guys do it next semester or if you do it over the summer. I think you guys do it in the summer. And so she happened to have Narcan from her Narcan training, and you guys will all get it. And she was like, somebody said, I see pipes, I see stuff in his car, maybe this is a drug overdose, because they were doing CPR and nothing was happening. He was a really young guy, and he just driven off the road. And so she's like, I've got Narcan in my car. She went and she gave him Narcan, and he woke up. We're going to talk about Narcan in a second. Yeah, go ahead, Macy.
Narcan is kind of like dextrose, so like make it to overdose, it's better to give it.
Yeah. It doesn't, so I want to be clear, it's not like dextrose, we're not talking about blood sugar. Narcan is an antidote, but yes, it won't hurt you if it's not an overdose. Yeah. If it were, so yes, exactly what you're saying. It won't hurt you if it is an overdose, or if it's not an overdose, so we just give it. Yeah. Go ahead, Evan.
Is there a way to get like free Narcan?
Yeah.
Like my Narcan fund is expired.
Yeah, so I think if you call the health department, Strong right now is going to bring all of you guys free Narcan, and they do it through a grant. You can buy it at pharmacies. I don't know how expensive it is. Does anybody know how expensive it is at the pharmacies? But you can get it at any pharmacy. But the county is doing some work trying to get everybody free Narcan, so I would just call the health department. So, and not a bad idea, right? But you go through a training course to kind of be able to recognize, so like you just don't come across somebody who's sleeping and give everybody Narcan, right? But you have to, but just trying to help them.
Is it one of those things where even if it is expired, it's better to give than to not give?
Yeah, absolutely, because the expiration date on drugs, I hate to say it, that's like the safe date, but drugs still work after that. They might not be as effective, maybe they work 75%, Typically, though, I mean, like when we send drugs overseas, we let them go within a year. So if it expires December of 2018, we'll use them as long as it's within December of 2019 because we know they're still pretty effective, if not completely effective. So something is better than nothing in that case. Yeah, and then you're always going to be calling 911. Now here's the problem with the opioids, right? We're talking about the opioid epidemic, and the opioid epidemic is a huge epidemic. And there's like all this research coming out saying that it used to be an addiction issue. Now we're going into an overdose epidemic. Like now it's not just that we have more people who are overdosing than we have who are just kind of walking around using. It's humongous how many people are doing it. But here's the problem. Is it possible for people to have severe pain and need something severe for their pain, but they're not addicted to it? Or maybe they are addicted to it, but they're not abusing it. Is that possible? We have a real problem in our healthcare system, and this is something that your generation is having to figure out. I actually just wrote an article about this, we have a lot of people who have significant, serious, legitimate pain. They're not drug seekers. They're not doing it just because, like, I have an addiction or something. They have serious, legitimate pain that nothing will help with except opioids, and they can't get the pain medication that they need because all the providers are afraid of prescribing an opioid and looking like they're helping somebody become addicted. Has anybody seen that situation? Have you seen somebody who was in pain? Abby, you want to talk about it?
I just work in like an orthopedic office, so like I see like people who are have like opioid or have
Yeah.
like severe like bone like arthritis or I mean like a bunch of different diseases and stuff like that, or
Yeah.
bones even that don't heal, or and they're like legitimate thing. It's like a 75-year-old woman with an opioid and like they have this thing, it's called I-Stop. I don't know.
Yeah.
And like, so they're constantly like, if you I-Stop her,
Yeah.
you have to like look to see like if she's getting other drugs from like her.
Yeah.
Or like something like that.
So here's the thing. How can you tell if I have a headache? Can you tell? I'm like, I have the worst headache. I don't believe how bad it is. I can barely stand up. Can you give me some pain medicine? Right? Can you do labs to measure if I have a headache? Can you do an x-ray and see if I have a headache? Even with back pain, right? And so unfortunately there are some diagnoses, and orthopedic stuff gets called out, right? Back pains, headaches, those are things where people who are drug seekers, unfortunately, those are like some of the diagnoses that people use. But does that mean that everybody who has a migraine is really a drug seeker? No. So New York State and some other states, lots of other states have some kind of, every state has some kind of a program, but in New York State it's called ISAP, other states use it too. But basically, before I can write a prescription for somebody, I have to enter it into this ISTOP program that's registered with the state, and I can look down through and see, like, so if Cynthia is my nurse practitioner, Cynthia can say, oh, okay, so Jen had a narcotic last week from Highland Hospital, and she had a narcotic prescription 3 days ago from Rochester General, and now she's coming to me, and she's got the same complaint, and there's this going on, right?
Isn't that with all controlled substances?
Yes. Yep. Yeah, not just opioids. It started with just opioids, and now it's being expanded out. But it's mainly focused, like amphetamines, so it's like the things that are really highly addictive. But it's mainly focused for like opioid stuff, okay?
You can see like, so say Crutchfield were like prescribed me 25 hydros, I'm supposed to take protection, she prescribed me a week ago, and I call her, and I'm like, I need more pain medicine.
Yeah.
That just shows that they're taking way more than.
And it's heartbreaking. I've had people say to me before, like you're never gonna guess what happened. I dumped my pill bottle down. I had my pill sitting on the side of the sink, and I hit it accidentally, and my pill bottle went down. You can't renew that. Like if you gave them a whole month supply or something, like we don't give a month supply anymore, but we did when I first came out of being in MP school. If they had like chronic pain that was like documented and everything, but you can't give them another supply. So like if you gave me an 8-day supply, and I say I knocked them down the sink, I might have really knocked them down the sink, but you can't give me another supply until those 8 days are over, and then we have to justify why are we doing it, what kind of pain are you having it, what's going on, right? So there's some pros to that. There's also some cons to that.
I interned in a pediatric office, and they had it like enter like the like Ritalin for kids who are being prescribed it, and then they'd have to send it to school because if the kid didn't get it, they'd test their levels, and the parents would end up taking it.
Right. Yeah, that's a huge issue, a big problem with amphetamines, right? Amanda.
So, I mean, the other thing is like, with stricter regulations with prescription opioids and with making up or not used, yeah, I mean, we're into unregulated street drugs.
Yes.
And that's when I mean, like, so.
So do you
it's
know?
like, it just seems
Yeah.
like the regulations haven't, it's redirected well.
Yeah, it's awful. And so what happened was the CDC came out with guidelines that said you should not be prescribing more than 3 days of something. Which how can anybody say anybody with any kind of surgery you can have 3 days of pain medicine? Right? Come on. Like, you're going to tell somebody who has rheumatoid arthritis and has long-lasting pain, somebody who has sickle cell anemia. Who knows what sickle cell anemia is? What's the major, has anybody ever taken care of somebody with sickle cell? It's incredibly, incredibly painful. Like the pins and needles you get when your legs are waking up? They have that all the time in the most severe way because the blood can't get through, right? These people who have sickle cell anemia, they're on huge doses of narcotics just to be able to function and kind of get through. And then, so you give them surgery, you can't take them down off of that pain medication, right? But the CDC came out with guidelines that said this is how everybody should do. And the providers got scared because the provider said, I don't want to lose my license, I don't want to get sued, I don't want to do this stuff. So all of a sudden the focus became on all the safety and preventing more addictions instead of taking care of people who already had severe pain did not matter anymore. And it's been so incredibly frustrating for me because I think the problem is that we prescribe too many narcotics. My daughter when my daughter was 12, she had to have oral surgery. They gave her enough codeine for a month and a half. Come on, a 12-year-old, right? But he was like, well, this way you don't have to call me again. That's not right. But then giving people who have severe legitimate pain, she needed it for a couple of days, but she didn't need a month and a half of it, right? He's asking me to go out and sell it. You know what I mean? And so there has to be some kind of middle ground, and there just hasn't been. We need to work on that more. And that's what I'm giving all of you the job of doing. Good job. Good luck. Evan.
I know a physiatrist who had a private practice out in Newport.
Yeah.
And I asked him about the opioid epidemic, and he was like, well, it just got to a point where after a couple of years he just stopped prescribing opioids because, it just, not that he was scared, but it was the amount of work. Because if he went on a vacation, and he doesn't have a PA or an NP, he would be the one that had to deal with it. But he also had a PT in his clinic, and
Yeah.
And he was also one of those other things where he would drug screen them all the time.
Right.
And if you were, if I had free drugs, he's like, I'm not doing this.
Right. Yeah, and there's legitimate cause for it. People can sell it. One hydrocodone will sell for $80 depending on where you are, which town you're in, right? So there's legitimate reason for concern, right? There's so many people that are addicted to pain medicine. There are how many have you? I'm sure you guys have seen there were reports of doctors and PAs and. I've only seen one case where there was a nurse practitioner. It broke my heart. But people just basically having drug mill, right? You have a clinic. Yeah, you're basically just selling your drug pads, doing different things. When I first started as a nurse practitioner, the DEA license was $150 a year. As all the opioid stuff started coming, the last I knew it was $450 a year. So they're trying to limit who, I have to have a really big investment in order, so I stopped prescribing narcotics because I wasn't prescribing that many anyways. But so it deters some people, but there's bad people out there. There's bad providers out there who are just selling them. There's some guy in Florida who was selling he was prescribing 650 prescriptions a day, not pills, 650 prescriptions each day. He was just signing them.
I had an orthopedic surgeon who was doing, I broke my wrist and I went to him and he got, while I was in a cast,
Wow, it's crazy. So the iStop program is helping with that, but people still find ways to do it. It's really, really sad. So there's a double-edged sword here. On one hand, we have people who are abusing it. On the other hand, we have people who need it and can't get to it. How do we fix this, right? So that's your generation's challenge. Yes, fix the problems that came before you, for the people before you caused. Okay. When we think about opioids, so the thing is, I don't want you to be, the whole point of this is don't be afraid of giving people opioids. Make sure that you know why they're taking them. Make sure that you understand their health history. There are going to be some people who are on super high doses of it. Look into their background. If they have something like rheumatoid arthritis or sickle cell anemia, it makes sense. If they have a long history of something that doesn't seem that severe, find out more information about it. Okay? I haven't seen nurses run into issues giving medications that are prescribed opioid medications, but just always know what you're giving and why. And then be an advocate for your patient if they're having serious pain. We aren't going to memorize all the different kinds of opioids. I want you to know that there are some that are natural, right? Do you know where opioids come from in nature? Puppies, right? Think of the Wizard of Oz. Puppies will make them sleep, right? And so codeine is not as strong. You need to know that codeine is not as strong as morphine. Okay? For a long time, morphine was our standard. Now our synthetic opioids are a lot stronger than morphine. Morphine used to be the strongest opioid we had, but now we have these synthetics that are stronger. We're going to talk about that more in just a second. We can use it for severe pain. We also use it for cough syrups. Have you ever taken like a codeine cough syrup to help stop the cough? You don't have to know this. You definitely do not need to know the mode of action. That's just for the people who just love the brain chemistry of it. That's just, but you need to know the things in black. You don't need to know the things in red. Okay? Everybody, put your arms out like this. Imagine that you're a big O, okay? And I want you to kind of like rock back and forth real slowly, right? Opioids slow you down, right? Say it. Say opioids slow you down, right? What is an opioid? Knowing that, with just that, what do you think opioid is going to do with my mental abilities? Slow you down. What's it going to do to my bowels? Am I going to have diarrhea or constipation? Slow me down, right? What's it going to do to my heart rate? Slow. What's it going to do to my respirations? Slow. The number one, write this down. The number one assessment. I love that you guys are getting into this. You're embracing the weirdness of pharmacology. I love it. The number one assessment we always do on a patient with any kind of narcotic is a respiratory assessment. Okay? Constipation isn't bad, but it's not going to kill you. Slowing my heart rate down a little bit is bad, but it's not going to kill you. It's not going to slow down enough to kill you. It can slow respirations enough to kill you. Okay? What does euphoria mean? Yay, right? So that's like kind of that happy kind of woo feeling. Okay? Excellent. It's going to make people sleepy. And this can happen very fast. I've given morphine before. The person was awake and talking to me. I give them morphine. I come back 5 minutes later. It scared the crap out of me. This guy was totally passed out. His blood pressure, he had gone from, his blood pressure had been fine. It was like 128/70 or something. All of a sudden, he bottomed out to like 70 over. I had given him an IM morphine. So it was just IM even. And like I came back like 5 minutes after I gave it, and his blood pressure went down to like 80/60, and he was completely passed out. Scared the crap out of me. It did? Yeah. So we're putting on oxygen and thinking about Narcan. All right. This is something that the CDC.
I'm so sorry.
This is something that the CDC came out with in 2016 when they first came out with the guidelines. And they came out with this MME, morphine milliequivalents. Okay? And they said there's all these different opioids, there's all these different narcotics. How do I know how much, like if somebody, let's say that Noelle is my nurse practitioner, and Noelle is giving me so much, let's say that she's giving me 10 codeine tablets. But then let's say that I go see Cynthia, and Cynthia says, well, I think you need some oxycodone, but I don't know how that compares with codeine. So there became a kind of a regulated idea that when we look at morphine, I know this is really small and I apologize, but if we look at morphine is one morphine milliequivalent. That makes sense, right? When we look at hydrocodone is the same as morphine. Hydromorphone, have you ever heard of hydromorphone? Anything with morph in it, that's a strong one. That's worth 4 morphine milliequivalents, okay? So what I want you to know from this is that codeine is the weakest opioid. It's 15 to 20 times weaker than morphine. I want you to know that morphine is 1 morphine milliequivalent, right? So that's kind of our standard. I want you to know that fentanyl is stronger than morphine, 2.4. Yeah, go ahead. You have to memorize the numbers, just know fentanyl's stronger.
I'm kind of confused about the codeine, because wouldn't it be like 1.7 stronger? If it's 1.5?
It's not stronger, it's not as
Or
strong.
weaker?
Yeah.
Well, you
Did I say
said
15 to 20 times? I'm sorry, I messed that up. The math to me is not important. Clearly. That's picking on me, not you, Stephen. I said that wrong, though. You're right. It's not 15 to 20 times weaker. It's just that it's weaker. Okay, just know that codeine is like a fraction of the strength of morphine. And then I want you to know that morphine is kind of in the middle. Fentanyl is 2.4. Okay, and then I want you to know just oxycodone. So if we look at strengths of things, codeine is the weakest, morphine is kind of in the middle, oxycodone is a little bit above morphine, and then fentanyl is like over twice as strong as morphine. So just know those 4. I want you to know codeine, morphine, oxycodone, and fentanyl. And that's the order of their strength from weakest to strongest. Go ahead.
Methadone.
Yes.
I mean, I know someone that was like doing like a psychiatric rotation.
Yeah.
He was saying that like people would have to get there at like 5 o'clock, 6 o'clock to
Yeah.
get their methadone? Like,
So
what, I don't-
methadone is an opioid, but it's easier to wean off of than heroin. So we use methadone. Sometimes people are on methadone for pure pain relief, okay? But sometimes we use methadone to try to wean people off of heroin, okay? So sometimes if we know that I have a heroin addiction and I'm trying to get off of it, I go to a methadone clinic and I do drug testing and I do different things, and every day I get my little dose of methadone. I can only get it from them, and I have to take it right there while I'm there. Yeah.
The same thing as Suboxone, or is that
Suboxone is specifically for like pills. I mean, think of like pills, okay? So it's like the opioid painkillers. Methadone is more specific for heroin use. The Suboxone is kind of the same thing, that it's easier to wean off of Suboxone than it is to wean off of hydrocodone. But Suboxone is used specifically for opioid prescription painkillers, okay? Is it what?
You still titrate it?
Yes. And only certain providers can prescribe Suboxone. You have to go through a special training and you have to buy a special license to be able to prescribe Suboxone. Methadone, I don't know if that's true with the methadone clinics. I know it's true for Suboxone though. Okay.
Also, isn't she not prescribed Suboxone for pain?
Yes, it's not. It's really used just for helping people try to wean off of it. Here's the thing, though: some people are never going to get off of it, right? Some people's brain chemistry. Some people can use, like, I'm going to go back to alcohol just because I think it's kind of a common denominator that a lot of people understand. You know, some people can drink a little bit of alcohol and then they're like binging and they're addicted, and other people can drink a little bit of alcohol for a long time and they never really have those signs of addiction. It's the same thing with all drugs. Although heroin and the stronger opioids seem to really be pervasive on how many brains are affected by it, but addictions work very differently in different kinds of brains, and you can't can you tell by looking at me if I'm going to get addicted the first time or if it's going to take me 5 times? You can't. So there's a lot of people that they use it once and then their body is physically addicted to it. They're going to be sick if they don't use it. Okay. All right. How are you doing with this stuff? Any questions? Any comments? Anything like that? Okay. Yeah, so, thank you. Okay, so this is what I want you to know. Okay, so, you need to know in general things about opioids, but I'm just listing them in order of weakest to strongest. Okay. So these are the opioids, just kind of like know that order, okay? So this is weakest to strongest. All right. We're going to talk more about addiction stuff when we talk about the Narcan, okay? But we're just going to keep kind of moving forward. We talked about, what's the difference between tolerance and dependence? What's tolerance? Right, you need more to get the same effect. What's dependence? Right, I can't function either mentally or physically without it, right? Withdrawal symptoms are just like sweating, nausea, vomiting, muddy, confusion, irritability. Notice all the things. So again, this goes along with all the slow stuff, right? So my blood pressure is going to drop. Urinary retention is huge, right? That's another assessment you want to make. But the number one assessment we're always going to make with opioids is going to be respiratory. Okay, let's say that I have somebody with COPD and I give them a codeine cough syrup. Is that a good idea? No, right? So we need to make sure that we are really careful about our protecting our respiratory. We're not going to give it to people with head injuries or increased intracranial pressure. Why? It causes hypotension, so it shouldn't increase it. There you go. So it does cause some vasodilation. The other thing is that the side effects, the sedation and the confusion, also mimic intracranial pressure. Okay, so how would I know if my side effects are from the intracranial pressure or from the drug? Okay. Respiratory disorders, and we're not going to give it to people with shock or hypotension because of what Melissa said, right? If I'm shock or hypotension, my blood vessels are already vasodilating. I don't want to vasodilate it more. Okay, and also the same thing. Somebody whose blood pressure is low is going to look kind of sedated and confused. All right, so here's some more information specifically about morphine. So morphine will be the thing that we talk about just in general when I ask you the questions. But AMI, do you know what that is? Yeah. So we do end up giving it to people with a heart attack because it slows down our respirations a little bit, but because it causes vasodilation, it decreases our myocardial oxygen demand. Write that down. That's a fancy phrase. NCLEX loves it. Okay? So giving morphine to somebody who's having a heart attack, because of the vasodilation, it decreases the myocardial oxygen demand. But clearly we want to be careful how much we give, right? The dyspnea from pulmonary edema, same thing. It's going to cause some vasodilation. It's going to help it so that we are transferring more blood, more oxygen, but also it helps with the anxiety. Okay, if you felt like you were drowning, wouldn't you start breathing faster? So this is going to slow us down a little bit and take the edge off. Okay, so we're going to give just a little bit. It crosses the placenta. Do we want to give it, and breast milk, do we want to give it to breastfeeding moms? No. And then, so pruritus, so itchiness is a common side effect, constipation, anorexia, all that. You feeling okay about that? Make sense? All right, wonderful. Now, who knows anything about Nubane? Are you going to answer a question? Yeah.
Why would you give it to someone with cancer?
Cancer, when we think of pain, we think of cancer as the most extreme pain. Cancer is like there's a tumor that just keeps growing and pressing on things, and we think of bone cancer as being the worst kind of pain as in a cancer patient. Narcotics tend to be the only thing that really attacks it. Okay, that's a good question. There's other things that we can use too, and we try to, but typically pretty high, lots of high doses of narcotics are going to be used for people with bone cancer and with different kinds of cancers. Okay. All right, what do you know about Nubane? Yeah.
It's used in labor and delivery.
It is used in labor and delivery. How come?
It doesn't like slow down the progression of labor as much as like some of the other pain medicines, and also I think it doesn't cause COVID to the fetus.
Right.
As readily.
Right. It does go to the fetus. The baby will have some decreased respirations. Right. Sometimes we have to give the baby Narcan, but it does not cross over as quickly as narcotics does. It doesn't bleed over as much. Okay. So. And like you said, it doesn't slow down the contractions, right? So doesn't that sound cool? It's a mixed opiate agonist and antagonist. How could it be an agonist and antagonist at the same time? It's crazy. It's Voldemort and Ron Weasley all together in the same body. That doesn't work.
Is it like the difference because there's like mu, kappa, and delta opioid receptors?
Yes. So it just has to do, right, and that's, you don't have to memorize that, but it just has to do with parts of the drug are felt on different receptors. So at the same time, so sometimes we see people who have opioid addictions that they might take, if they have really severe pain that nothing else is helping with, we might give them Nubane because it's not as big of a hit on those opioid receptors as like morphine, but it's still going to give them some pain. Let me back up for just a second. Let's say we have somebody who comes to you and they're a recovering heroin addict. And they're having incredible, horrible pain. They have some disease documented. There's something horrible going on. They got their hand smashed, and you can see the inside of their hand like pushing out. And you give them Tylenol. Is that okay? How do you know what to do to treat somebody who's in addiction recovery?
I mean, I don't really know how they figured that out, but I asked that question when my dad was having knee surgery, and they gave him Dilaudid even though he has like history.
Yeah.
But I don't know if I don't know what they just think that like that's really the only thing.
So here's the thing, and you need to write this down because this is important. When you have somebody who's in addiction recovery, first of all, we let the patient decide, what are you comfortable with? There are some people that fought so hard. You know, once you have, think about something that you just love. Maybe it's shopping. For me, it's chocolate. If I don't have chocolate for a long time, I'm good without it. But as soon as I have a little bit of chocolate, I need to have more, okay? So think about something like that. Sugar is like that. And it's the same way with using drugs if you're in recovery, but it's a much more powerful thing, right? But you need to talk to somebody. So like, let's say Andre's my nurse, and Andre says, Jen, I know you're going through this recovery. You're having really horrible pain. The NSAIDs aren't covering it. What do you feel comfortable with? And I'll say, I'm okay with the pain. Don't give me that back. Or I might say, you know what, this pain is too much. Is there something low that you can give me? So maybe like a low dose. They would probably use Nubane rather than doing something straight. If they gave your dad Dilaudid, so people who are having like really, really horrible pain, we have to make sure that we're not ignoring the pain of people who are in recovery just for the sake of helping them stay clean, right? It's kind of torture to be in horrible, horrible pain. So sometimes we do use a stronger medication depending on what they're going through. We just have to watch them. We have to work with them, let them know that they're not being judged, and then just be prepared that maybe we're triggering something in them and we have to help them get off of it. I'm going to tell you it depends on the provider's comfort, it depends on a lot of different things, but generally the patient is part of that conversation. Okay? Sometimes you see Nubane used in those situations. Okay? How you feeling about Nubane? Feeling good? Okay. All right, we're doing great. All right. So here's our side effects for the Nubane, right? So we have depression, restlessness, abdominal cramps, respiratory depression, and then this is all the stuff that we just talked about. Okay. How about this? Do you guys need a break? Like you guys getting antsy or anything? You okay? We actually don't have we have a little bit more to go through. Can I cover the Narcan and then I'll give you guys a break if you need it? Do you need a break or no? You're doing okay. A little bit of a break? Okay, let me get through Narcan, and then I'll give you guys a 5-minute break, okay? All right, so we've been talking about Narcan a lot. Narcan comes in a couple of different ways, and you don't need to know how it comes in, but the thing that's sold over the counter and the thing that you're going to be given in your Narcan training is a nasal spray. We can also give it as an IM injection, okay? The first time that I gave Narcan in the emergency room, I did not know what to expect. And they said, or I wasn't giving it, somebody else was giving it, but I was part of a team. And they said, stand back. Like this guy, he was like completely out of it. Eyes were rolling back in his head. He was all sweaty. And he just was like we couldn't get him to breathe. It was really scary for me. And they were like, stand back, we're giving him Narcan. And I was like if this was my patient, I was like, okay, because I was terrified, I'll be honest with you. And they were like, no, seriously, stand back. And I was like, okay. And somebody grabbed me and was like, stand back. And they gave him Narcan. He was completely out. He wasn't breathing. I couldn't get a pulse. There was nothing. They gave him the shot of Narcan. And within 30 seconds, he jumped completely up off the table. And he was punching and he was yelling and he was just all this stuff. And I was like, holy crap, what did you do to that person? And then we had to restrain him. And then we were like, I was like, well, now let's give him some Xanax because he needs to calm down, right? Not a good idea for me to be prescribing at that point in my career. But Narcan works really quickly. It binds with the receptors for the opioids, and it kind of shuts the door. And so we can bring somebody back. I want to show you something. That's how it used to be. With the drugs that are on the street now, we don't see that drastic of, Molly, could you get the lights for me?
Get your mail card center policy. Talk to us initially. Any drug use, however, was pinpoint. Respirations were continually slowing. So definitely air loaders, known user, gets the next to Narcan. Respiratory rate's about 6 a minute right now.
Narcan going in, I'm eating right now.
0.5.
This is in Greensboro, North Carolina.
Talk to me. Hi, Bob. Open your eyes. I'm talking. You're talking, you're fine. Yeah.
Hey, now you come around to us.
Yeah. You went out on me. I went out on you? Yeah. Not really. I mean, I've been pretty much, you remember everything that happened? Yeah. So you never stopped breathing? No, it's not. I don't remember stopping breathing. Okay. You remember us putting the tube down your nose? Yes. Okay. Well, listen, partner, you're not in any trouble. I just need to know because I had to give you Narcan to get you breathing again. Okay? So be straight. I need you to shoot straight with me. When's the last time you used? Haven't. Eventually you did admit to using what they call a 5-bag or $5 bag. Stated it's from his typical supplier. It was his typical dose, but evidently it had been cut with something different than what he was used to. You're willing to accept the risk that you could possibly die from this, correct? Yes, I did. But I'm not going to. They're like any other patient. They have the right to refuse any further care, which you did. So you're willing to take that risk? Yes, sir, I am. Near 99% of them will refuse every time they're willing to accept the risk of death. Never had to have Narcan used on you? Well, finish your laundry. Hey, let's let you, listen, there's a lot of help out there for you. Alright, go look for it. I don't want to be too late one day.
Never underestimate.
Okay, so I told you my experience when somebody overdosed from heroin. How come his response was not as significant or was not as like dramatic? He just kind of like looked like he was kind of like just waking up. What do you think?
Maybe because of what the drug was cut with, it wasn't on the same receptors.
Mm-hmm.
But Narcan, I'm sorry.
Exactly. Go ahead.
Could it also be that there's just not a lot of oxygen in this system? It's just
Oh, that's actually really good thinking. I think it has more to do with the drugs that are being cut now, but that was really good thinking.
It's like I had that happen to me, and we get the, like the nasal, and he was slow to wake up. His O2 stats were like B5.
So like there just wasn't like enough like pressure bringing the Narcan into his body. Is that what you're thinking? Wow, I hadn't thought about that. Good job, Evan. Go ahead.
Doesn't Narcan not like work as effectively on fentanyl?
Yes, and we're gonna talk about that's where we're going with this. Kristen.
And EMS is doing a lot of training on pre-oxygenated before doing Narcan because of the high oxygen. So
That's great.
They're linking that they're waking up aggressively with the high oxygen.
Okay. Yeah, I didn't know that, but that makes sense, right? If you stop breathing, then you're waking up in this hypoxic state when you do wake up. That's really interesting. Okay. So I find like there's new information coming out all the time about it. So whatever you know now, you have to be prepared that you're going to have to learn more and more about it, like every year, just stay up with what's going on. But what happened was drug dealers got, just kind of business savvy. And if I can if I can sell this much to you for $5, or I can sell you like this much, but I'm going to cut the rest of it with Tide detergent, then I'm going to cut the rest with Tide detergent, something that's cheaper. So that was one issue. So we've had lots of problems with things like that. For a while in Rochester, there was an issue where cocaine was being cut with something that was dirty, and for about 3 months, you could tell whoever had been using that batch of cocaine because they had like this necrotizing fasciitis. So like their nose was like rotting off, it looked like, and like just like all this black and bruise, and like the skin was like being eaten away. And we see those kind of like bad batches come through the area from time to time. In this case, commonly heroin is being caught with fentanyl. So fentanyl is just another opioid, right? But fentanyl has a much longer duration than heroin. Why would I want to mix something with heroin that had a longer duration?
Because people get higher from it, so then they're going to tell their friends, and then more people are going to
Right. So it's like, instead of just Coke, I'm getting cherry Coke, right? And so I'm getting like a little extra for my money. So it lasts longer. So fentanyl, Narcan has a duration of 45 minutes. You don't have to memorize that, but just kind of keep it in the back of your head. Narcan has a duration of 45 minutes. Fentanyl, I think, has a duration of 2 hours. Okay? So let's say that Evan finds me, and I'm completely unresponsive, and he gives me Narcan, and I start to like slowly wake up. If I still have that fentanyl in my system, 45 minutes later, the Narcan's worn off again. Am I going to keep talking? No. I'm going to go back to that overdose state. And so sometimes we're having to give people multiple doses of Narcan. The drug scene is changing so much. You know who really stays on top of like what the new drugs coming in are and the counterfeit people? The poison control, right? Are you guys very familiar with poison control? Has anyone here ever called poison control? Yeah. They are experts, and they're amazing researchers. If anything happens that somebody gets poisoned by something, we always call poison control. Like even working like in the emergency room, like you never trust that you know the most up-to-date stuff. You always call poison control. But they keep up with all the new drugs that are coming in the area, how many people are dying, how many people are having issues and stuff. So give them a call if you have projects to work on or anything. They have great information. But the problem is there's just always so many new drugs coming in. I was just reading over the weekend that there is a new batch of opioid drugs that Narcan no longer blocks the receptor. So now they're working on a different receptor than what Narcan blocks, so Narcan isn't working. Okay? Go ahead, Melissa, and then I want to say something.
I was going to say, I just saw this thing on a show that I watched about how fentanyl is so incredibly easy for somebody with like chemistry knowledge to synthesize.
Yeah.
And that's also why it's so big, is because there are all these labs, like you would have thought like maybe like a decade or two ago, like about meth labs, but they're fentanyl labs, and they can produce so much
Right.
and then sell it.
It's amazing. For a while I blamed Breaking Bad. Did I like that show, Breaking Bad?
Okay, so the guy they were showing,
Yeah.
he was kind of like the guy from
Yeah.
Rich Stuff.
And my husband loves that show, and I would be like, stop watching that show. It's influencing people to make drugs. But they're making them anyways before that show. Yeah. Jenny.
In that video, was that in a different state?
Yeah, that was in North Carolina.
Do they have like the same like mental health arrests?
No.
So in New York, we wouldn't have let that patient just
Yeah.
go.
I know.
Okay.
It varies. It really varies from state to state. So the patient has the right to say, I don't want to be treated. And so they were going under that. But I know, like now, so now there's this whole new approach actually to taking care of people who overdose. Like rather than arresting them and sending them to jail or, whatever, even if you're not overdosing, if you're just found with stuff on you, different states are using it. I don't know where New York State lands in this, but in West Virginia, where entire towns have been demolished by opioids, they are starting a new approach where when the police are walking down the street, the police are just taking kind of a friendly approach rather than trying to arrest everybody. They're taking a friendly approach. They have social workers everybody's just kind of like, the police are dressed in police uniform, but the social workers and the drug counselors are just dressed in like street clothes, and they're like, can I come in? Like they're coming into like squat houses where people are like using drugs and stuff, and they're like, can I just come in and talk to you? How's it going? And they're just trying to be more of like, not judgmental, more welcoming, trying to get people in. It's not always going to work. Anybody from, I think it's Ithaca. Anybody from the Ithaca area? So the mayor of Ithaca actually started the first program in New York State where people can have like, it's like a heroin clinic. It's like a clean heroin clinic where they can come in and get free needles and they can get heroin that they know is clean, that's not cut with anything. Why would a mayor of a town want to do that? Say that, Macy?
They have like a high, well, Cornell,
Yeah.
have a high suicide overdose rate.
They do. And so they said, rather than, if we know you're going to use it, at least come and get stuff that we know it's not going to kill you. And then this gives us a chance to talk to you about trying to get better, about trying to recover.
Yeah, I was gonna say like no matter what laws like they enact, people are always going to do
Mm-hmm.
drugs and people are always using heroin. But it's like if you make it so that they can get something where like they know
Yeah.
that it's just that drug, then it actually like decreases the amount of people
Yeah.
that end up dying. It's kind of like the thing with like the THC vape cartridges.
Yeah.
Like people resort to going and getting those from like a black market source.
Right.
Because there's no way for them to get something
Yes.
where they know what it is.
And this, going back to what Amanda said, I started to talk to you about, kind of like feed off of what you said about if people can't get like prescription painkillers, then they're going to start turning to things on the street. Well, if we know that, we definitely see that there's that that trend happening, that people are using marijuana, that people are using heroin, cocaine, different things to try to like relieve their pain, anything to relieve their pain, and now they're addicted. Let's try to like, they're open to it. Let's try to like bring them back to it, right? Go ahead, Evan.
You're saying that they're like giving real heroin?
Yeah.
How does that, the CDC schedule?
Yeah,
laws?
they had to get all sorts of special permits and all sorts of special things. So I don't know if this is where you're thinking, Evan, but does it make sense that some people are like, are you kidding me? We're giving free heroin and needles to drug addicts, and now we want them to get better? Do you see that there's like a flip side? We can sit here and go kumbaya all day long, but in the real world, like, taxpayer money is going to pay for this heroin so I can come in off the street and use my heroin. I don't have to stay there. Nobody's giving me religious stuff. There's no other, which for some people, I saw, the reason I mentioned that is there was somebody who said, well, at least if you gave them a Bible, it would give them something. So that was what somebody said. But what they do is they do have counselors there, and they're talking to them. When I come in and I need a fix, I am not able to pay attention. I am just sick. I am like physically sick, and I can't like really focus on anything. So, but there's a counselor talking to me. How you doing? I know you're not feeling so good right now. Are things okay? They're establishing trust with me because they say I'm going to help you. And then when I start feeling better, I do the fix, and I start feeling better. Then they're still there saying, you felt really bad about 5 minutes ago. Do you want to find a way that you don't feel so bad anymore? So they're using that as a pathway. What do you think about that? Is it going to work? You think so? There's no wrong answer.
Oh, I mean, Vancouver already did it.
Yes.
Before, and they showed 10-year increase in life expectancy.
Really?
Decrease in unemployment.
Okay. I knew Vancouver had done it. I didn't know they had those great results. Like I knew Vancouver was like ahead of us with that.
I also think there was a country in Europe, I can't remember what country, but a few years ago they like decriminalized all of their drugs, and they saw like a decrease in actually in people using them because kind of that like a little war.
Yeah, right. You know, it's hard though. It's a tough situation because when Colorado made recreational marijuana legal, they actually had an increase in crime. They actually had an increase in like mafia from other countries started going there, buying houses, and then like they were planning more than what was legally allowed, right? Because they said you can have some, but not a lot. But they started having an increase in crime, and the states around Colorado actually sued the state of Colorado because they had to hire more law enforcement, and there were more issues with car accidents and all sorts of things. I think our culture is set up to make things very taboo, and so I think it's going to take a long time for us to get to that point. I mean, I think Europe has kind of already been like, kids can drink wine, sex isn't so taboo. I mean, they're just a different culture. I think it's going to take a while for us to get there, but if we get there. But that's a good point. Go
I
ahead.
think it gets rid of like the cool factor too.
Yeah.
Like when you're in Europe, it's not cool to drink alcohol, but every like drink you do.
It's just one of those things.
Everybody did that.
Yeah, that's really interesting. So I don't know where it's going to go. It's like needle sharing programs. What?
Needle sharing, which stops the spread of
Yeah. So needle sharing, so we actually have some needle sharing sites here in Rochester that they say, you know what, I'm not going to be able to stop you from using drugs, but at least this way you're not spreading HIV, right, or hepatitis or something. What do you think about that? Do you think that's a good idea? Does it work? Does it bother you that your taxpayer money is going to pay for that? Macy?
I mean, I would look at it as my taxpayer money's either going to pay for that or for the.
Yeah. And that's really what it shows is that like the medical bills are, kind of crazy. So I don't know what the right answer is, but it is definitely a conversation that is going to be more and more on your generation of nurses. All right. So we have Narcan. Okay, let me do this real quick and then we're going to get you out of here. Not out of here for good, just a 5-minute break. Okay. Let's see, reversal of analgesia. Is there anything on there we haven't talked about? Ooh, it elevates the PTT. We can use it in neonates. Is there anything up there that you want to talk about? Okay. Take a quick 5-minute break and then come back to me.
Don't we have 20 minutes left?
Yeah. Can you sit through 20 more minutes? Can you hang in there?
Yeah.
Okay. Go. Yeah, how about that? If you need to take a break, take a break. Thank you so much for trying to hang in there, though. If anybody else needs to get up and take a break, I understand. Come on back. All right. So here's our practice question 1. Which is a common side effect or adverse effect of morphine? C, right? Because it slows the body processes, right? You love that turtle, don't you? Right? So it's got the O right in it. Slow. Okay. Now we're going to talk about drugs of abuse. You need to know the definitions for these words, okay? So what's the difference between drug abuse and drug addiction? I'm going to talk about alcohol for a little bit. Let's say that I have a glass of wine every night, and it doesn't really affect my behavior, and if I don't have it, I'm okay. Is that drug abuse or drug addiction, or not? Neither one of those? Okay. What if every time I get together with my friends, I drink so much and I kind of have blackouts? That's drug abuse, right? If I don't get together with them for a couple weeks, that's fine. But it's abusing alcohol. Like when I'm with them, I can't control the amounts, or I can't control. I kind of use it to excess, or just can't really control it. Addiction is I'm now, for some reason, I either mentally or physically need this as part of my life. Okay. We can have either psychological or physical. What would somebody with psychological dependence to a drug say?
Actually, that's really common with marijuana because it technically doesn't have the effect that can cause a physical addiction pathway,
Right.
but it does have a very strong psychological addiction. So some people would say I can't go out of the house without using
Right.
because of anxiety or they just say that their behavior they can't function
Yeah.
as themselves with that.
Several years ago, I had a nursing student who, a week after she started the program, she came to me and she said, I've really been trying hard to quit marijuana, but I can't get through the day without it. She's like, the longest I can go is about 2 hours. I've been trying for a month to cut back, and the longest I can go is 2 hours. Did she have a psychological dependence or a physical dependence? I mean, she said that she felt like it was a physical dependence, but really, then as she examined it, it was really just she just felt more confident, she felt better, her anxiety kind of built up on her. Okay.
If that was a nursing student going to go, would it should be
So actually, specifically with her, she had come to us before there were any issues, so we helped her get into a recovery program. And so, and then she was just really closely, but she volunteered to be close. It was either you're going to be closely monitored or you can't do this until you come back after you've been through recovery. So she was doing recovery while she was here, and she actually did a really good job. So it was a huge struggle for her, but she did a really great job. Yeah. We had to there were different, it's not like you guys going into clinical, but she did a really good job. don't underestimate how hard addiction is on people. I think it's very easy for people to be like, oh, well, I would never do that, or, you know, my family, gosh, that would never happen in my family. I have to be honest with you, it's in everybody's families at this point. You know, everybody knows somebody, there's something. The other thing, we're going to talk about this at the end, but just, you have to understand that when you look at the statistics about how many people have addictions, you have to know that there's going to be somebody that you're working with that probably has some kind of an addiction to alcohol, to drugs, to something, and how are you going to handle that? And what if it's you, right? How do you know? Like, nursing students are under a lot of stress, and so you go into nursing, it can be under a lot more stress. And if you feel like you're crossing that line where I don't have control over this, you have to reach out and get help. What that nursing student that did that was awesome, she reached out before it became an issue, she was like still working with mannequins, so we had plenty of time to like figure out what are we going to do about this, and help her get help before she started taking care of patients. And where people run into problems is that they don't have that self-awareness, and then all of a sudden I make a med error, or I'm caught stealing medicine or something, and then you lose your license, and then you have other issues. But if you come forward, typically, I've actually been the person in charge of, at one of the hospitals I worked at, I was actually the person in charge of taking care of people who had addiction issues, and we would do the monitoring and do everything. People come forward before anything happens, you will not lose your license. You'll be monitored, you'll have things you have to go through, but it doesn't mean you're going to lose your license. The people who lose their license are the people who mess up and aren't that self-aware. So just, you have to help people kind of see that sometimes, okay, if you see it in yourself. Tolerance and withdrawal, we've talked about. Any questions about those things? How about, oh, go ahead.
I've heard that there's a link between head injuries and like drug abuse.
You know, there's a link between lots of different things to do with the brain. We really know so little about brain chemistry and how our brain works. It depends on what kind of injury it is, but there can be emotional ability, like people who like hit like this part of their brain, like if they have like a side to side where their head is slashing back and forth, it can cause injuries. The type of injury it causes to the brain, the lasting injury, can have trouble. People start having trouble with addiction, where maybe they didn't have before. They have trouble with anger. They have trouble with emotional ability. Brain injuries where the head gets slashed back and forth. There are other things that can happen with that. And it just has to do with not just the specific area of the brain that actually did the initial striking, but it's just the way the whole brain. The brain is like jelly, right? So it like bounces back and forth depending on which way the force came. But we're learning that there's so many things, like people with ADD. Are they more likely to be addicted, or is it just that they're under so much stress that they self-medicate to get around it? So I think we aren't in a place yet to say specifically about, like, make broad general terms, but we are definitely researching that to try to figure out, is this what's happening? So we see it. But is it because people are stressed so they're self-medicating, or is it because they're more likely to do it? I don't know. So I don't know the answer to that. Okay, so stimulants, I'm going to go through some of these really quick. As far as nicotine goes, so I do want you to know the effects of it. Okay, really what you need to know from this side is really just the effects of it. This is how it's going to happen. When we talk about people trying to quit smoking, has anybody here tried to quit smoking before? You have to be incredibly patient. On average, it takes people 11 times before they quit. That means for everybody who quit cold turkey, it took somebody else 22 times before they were able to quit smoking. It is, the drug company or the tobacco companies have admitted that they have genetically changed tobacco to make it more addictive, to make the nicotine more addictive, and so there's lots of issues. So we can do like different kinds of nicotine replacement systems, right? We can do the gum, the lozenge, all that kind of stuff. Chantix is a drug that it's actually it causes a lot of issues. It's not nicotine replacement. It makes you not want the cigarette so much, but people have had some suicidal ideations on it. People have really vivid nightmares. It's not always a great drug for everybody, so we have to just be careful with that. You don't have to know anything about Chantix other than that it helps with smoking cessation. Okay? Let's talk a little bit about vaping. What do you know about vaping? Say it, Molly. That's what I thought you said. Sorry. That's what I thought you said. I'm like, Molly wouldn't say that. That was me being judgy. I apologize. So jewels are like little colorful things. I meant to put pictures in, and I'm sorry. But basically, you can vape anything, right? So there's some kind of like a little heating element, and there's like a mouthpiece, and steam comes out, right? And then the drug gets carried on the steam, goes into your lungs. All the little blood vessels that are in the base of your lungs absorb that in quickly. So drugs that we are vaping in, they get absorbed a lot more quickly than anything I would take as a pill form. And so we see people, I think we had talked about this maybe in Foundations, about about, like we have like a lot of people vaping Viagra, Cialis, CBD. There's actually a whole slew of drugs that are available in liquid form that people can vape. Okay, what do you know about people dying and getting hurt from vaping right now?
They're buying, like I was saying about like the unreliable like black market THC cartridges because they have additive ingredients in it that like say like you were like in a legal state
Yeah.
control the production of it.
Uh-huh.
They wouldn't have those ingredients. I think it's vitamin E that they found was like the issue.
Oh, no
'Cause
kidding.
It coats your alveoli.
Right.
And,
Yes.
yeah.
Okay, so I didn't know it was vitamin E. I knew it was an additive, but I didn't know it was vitamin E. But it's not just, oh, go ahead.
I knew it was vitamin E. Like I think there was like a couple pages where they found it was
Okay.
vitamin E. I think it's like more than that.
Vaping stuff has always had an issue, though. When e-cigarettes first came out, lots of people were getting sore throats. They were getting weird coughs. They found out that most of the e-cigarettes had formaldehyde in them and other chemicals that we know cause cancer. And so, and they still have the nicotine. So it's like, it's not really helping people quit smoking because it still has the nicotine. It's not just the THC things that are causing problems. It's also the flavored nicotine jewels that are causing issues for people, and there's a couple of different reasons. Some of it is there's something in it that's coating, and so it might be vitamin E for all of them, I just don't know.
Also, like with the jewels, I know the issue is like people who use the jewel, like you can hit it and get so much more nicotine than like if someone who smokes cigarettes
Yes.
would ever be putting in their body. It's so readily
It's
available.
so concentrated, and they're extra concentrated, but then also it's just going right through. I mean, although when you smoke a cigarette, but still it's different. There's different kinds, so I was doing some research on this, and there's different kinds of smoking. Like some people will hold it in their mouth and then breathe it in. They don't get as strong of a hit of those drugs. Other people just take it directly in. But part of the problem that people are also having with all of this is that the liquid is so superheated that it's actually causing some burns to airways. So when they've done autopsies on people who died, some of it is heat burns in the airways, some of it is chemical burns that's going on. So this is something that is evolving, right? There have been injuries going on since 2015, but for some reason over the summer it's just exploded, and now we're up to 33 people that have passed away. Oh, no, I don't know that. Tell me about it.
Well, I don't know exactly what the
Okay.
physiology is going to be. But
Yeah.
is that it's like creating hormones.
Oh, that's so interesting. You know, I think there's going to come a point at which we look back and we say, like now when we look back on the 60s and we're like, why was everybody using plastic now that we know that like it's showing up in the stuff? But it was just like this new thing, like it's so great. And I think there's going to be a time where we could like, how could we have chemicals in everything that's around us and not think it's going to affect us? And so, yeah, it's tough to see. So just kind of know those in general things about vaping, okay? Stimulants as far as caffeine goes, I'm not going to ask anybody for how much caffeine you drink a day, but in general, it really should be less than... As I'm drinking, I never drink soda, and here I am drinking my Coke first thing this morning. But Coca-Cola, not cocaine. I joke around about that, I know. But in general, the general guideline is if you drink less than 2 cups of coffee a day, then you should be okay. People who drink more than that, we can see huge increases in blood pressure, dysrhythmias, things like that. Okay. Here's the thing, though. You can go through withdrawal from. Anybody ever gone through withdrawal from caffeine? What's it feel like?
I did the list.
Yeah.
So that's the thing with the caffeine in the over-the-counter medications. Like, I get some headache, but I want to take it for my headache, but it was just caffeine.
Right.
Get rid of it. Yeah, my mom had the same. She was trying to stop Diet Coke and had the worst headaches.
Yeah.
And then she'd take except your migraine, which has caffeine.
Right.
She wasn't
So you have to go back to that. So the idea is wean off of it. If you're trying to get off of caffeine, then try to wean off of it. Yeah, go ahead. Yes, no, we're going to talk about this in a couple weeks, but the idea, the theory that we have right now about why people have migraines is that the blood vessels in the brain are spasming. And so caffeine, even though it's a stimulant, it helps hold the blood vessels kind of stable so that they're not spasming. And so even though it just holds them stable and it stops that spasming and it stops the headache. So, yeah. And we'll talk about that more in a couple weeks. We'll get more into detail with that. So just kind of know, basically I just want you to know that caffeine, you have to wean off of it. Know the things that we are, I guess that's it. Just really kind of know this part, okay? Okay. Alcohol, I'm not really going to ask you any questions about that other than There is a thing up on Blackboard that talks about how to help people who want to quit alcohol, and it's the same idea that we've been talking about with other drugs. Like, you just need to be welcoming, you need to establish trust, you need to take it seriously. If somebody comes to you and they say, I'm concerned about, I've had somebody, one time I worked with this nurse who was horrible, and there was a patient who said, I'm just really concerned about my alcohol intake. I'm drinking about 3 drinks a day, and if I don't have that, I just feel shaky, I just feel like I need it. And she's like, oh, that's not that much. My husband drinks a lot more than that. Don't do that. Okay. All right, depressants. So when we see people, we've kind of talked about the opioids. I guess what I want to talk about with this slide, things that we haven't talked about yet, is just the idea that people who reach a certain level of addiction, they start out, they might be having a high-functioning lifestyle, they might be able to keep up, but then as nurses, when we treat people for addiction, and this goes with any kind of addiction, it could be alcohol, it could be shopping, it could be whatever, people reach a point where the rest of their life is crumbling around them, and they may still be unaware that it's because of their addiction, but we need to be looking for those things. And so we see people, selling themselves, or they're in situations that they can't get out of, where they're being sold, where they have like poor nutrition. Has anybody ever seen the pictures of meth mouth? Right? And so I've had people who had meth mouth tell me, oh no, that's not from the drugs, that's from, my mom never took me to the dentist, right? We always blame our mothers. So, and then we worry about, it's just the lifestyle is such a harsh lifestyle that we see people sharing needles and having diseases. So just know that that's part of it, and those are things that we need to be able to look at. So if you haven't seen heroin, sometimes if you haven't seen this stuff, you might not recognize it as paraphernalia. And sometimes, I'll be honest with you, that they are, it's not always easy to kind of pick up. But you can see that they've got just the 1 cc needle there. This is a little piece of cotton this is like a broken can. They put the little cotton there to try to clean it out before they inject it in. So they can use a little piece of cloth, a little piece of cotton, whatever. And so they're kind of cooking it, melting it down, and then draw it up in a needle, and they'll inject it into their arms. So heroin, we joke about, well, I don't know if we joke, but we think about heroin just being white, but heroin can actually come in all different colors, like browns and grays and blacks. Okay, medical marijuana. Let's see. We're going to make this I want you to read through this stuff. I think with CBD becoming so popular, some of it you might already know. Let's talk about this. Is there a value to medical marijuana? Yeah. What does anybody know what a benefit of it is?
I used to work at an assisted living facility in Wisconsin, and a lot of our chronic pain residents were going over to medical marijuana instead of opiates. I especially had one resident who he had become addicted to the opiate medicine, and then he was getting capsules of oil. So he wasn't smoking it or anything, but he was getting capsules of the actual oil.
So, and then that helped him with his pain. Go ahead, Alyssa.
Stuff for people with Parkinson's.
Yeah, it really helps. Go ahead. Just more of that stuff. So what I want you to know about medical marijuana, I want you to know, first of all, that the laws for marijuana vary in each state. We talked about this in Foundations a little bit, but marijuana is illegal on a federal level. So the federal government, the DEA, the Drug Enforcement Agency, the FDA, they see marijuana as illegal. State by state, the states are taking their rights and saying, well, we're the state, we have sovereignty over the people in our state. We're going to say that marijuana is legal. And they can either say that medical marijuana is legal or that recreational marijuana is legal. Okay? And so I think it's somewhere in the 20s, it keeps changing, but I think it's about 23 states have medical marijuana legal, and less have recreational marijuana legal. There's lots of arguments saying which is which. I want you to know, though, the research that is coming out shows that marijuana loves to stay in fatty organs like the brain, and people's brains are not fully developed until they're about 25. And so we have not been able to do research really on what the long-term effects of people under the age of 25 doing marijuana is. We know that there is some effect on IQ and on ability to critically think and things like that, but because federally marijuana is considered a Schedule 1, no one who gets any kind of government funding can technically do any research on it because they're going against the law. Does that make sense? What do you think about that? It's tough, right? It's a tough situation. So I want you to know that there's a difference in the two oils that are in marijuana. So there's THC oil and there's CBD oil. And since CBD is so popular, you probably guessed, CBD leads to a lot of the things that are positive things, like helping with Parkinson's, helping with seizures. When we talk about seizures, I've got this great video I'm going to show you. There's a little boy who's having a seizure, and they rub CBD oil on his gum, and his seizure immediately stops. It doesn't happen for everybody, but it worked for that little boy. And so it helps people just kind of feel a little bit less anxious. It helps with migraines. There's lots of things to it. CBD it can give people a little bit of a euphoric effect, but it's typically not that. Usually the THC is the thing that's like, give people like the stoner symptoms, right? So the THC is what gives people the euphoric effect. Here's the problem though. All the stuff that's being sold over the counter, CBD, does the FDA regulate that? It's considered an herb or a supplement. And so THC is getting into a lot of CBD stuff. So please, I don't know if I talked to you guys about this or the juniors, but please be so careful if you use CBD because you're going to have to do a drug test for any job that you get in nursing, and some places actually do randomized drug testing. Be careful if you're using CBD. At this point, marijuana is illegal. Anything, whether you're using THC or CBD, it's illegal on a federal level. And so I don't know where healthcare employers are going to land, but if you're taking something and they happen to put a little THC in it, you might not know it, but you might be getting this. Also, just taking CBD, I don't know how employers are going to feel about that, so just be careful, okay?
I do know if you're getting your CBD that's somewhere, like where I'm from in New York now, they're turning like all the unused farm fields into a hemp field for extraction of CBD. If you're buying it from somewhere where it was grown in New York and produced in New York, it is regulated by like the state government.
Oh, okay, I didn't know that. Okay.
They have to test the plants before the harvest.
To make sure.
Yeah.
Okay.
And they can only have negligible amounts of THC.
Okay.
So when it's extracted, it's not.
I didn't realize they were doing. I knew they were doing that in another state. I didn't know they were doing it in New York State.
Like
Okay.
when I was just home, like they have the cops there all
Okay.
the time, and they have to come every day and check.
Huh. All right. Awesome. Thank you for that. All right. So, what we have talked about is pretty much. This is just kind of going over it. You don't need to know about the Compassionate Care Act, other than just. I mean, it's kind of. It's been there, but just kind of know about it. But this is what I really want you to focus on. You don't have to worry about, we're going to stop at the marijuana stuff. I want you to know about those two drugs, though. The nabiximols and the drobanol, Marinol, okay? So I'm going to say drobanol, dronabinol. These are drugs that have been out for a long time, for like 20 years, before medical marijuana was legal. And you'll still see them out. Okay, so just kind of know the basics about that. And then we are all set for today. What questions do you have for me? What? Yeah, we're not going to go through nothing from the last few slides will be on the exam. Okay? You guys did a great job. Thank you for coming today, and thank you for hanging in there. Make sure you get more candy. If you're celebrating Halloween, have a wonderful time. If you're not celebrating Halloween, have a great time anyways. Remember, next time we get together, we're doing the calculation test. So bring a calculator. You can't use your phone. Okay, we're going to do the drug dosage test. And that'll be the first 40 minutes of class. All right. Nice job, everybody. There's more candy up here if you need any.